Okay, thank you very much, everybody, for joining today's session. Once again, I'm Adefemi Adewemimo. I work with the Design for Health practice of Co-Creation Hub as a program manager. It's a great pleasure to have everybody join us to this spectacular, groundbreaking Pan-African event, roundtable discussion series, of which we'll be tackling healthcare data accessibility in Nigeria, lessons for Africa. This particular program, it's a series of events that will take place on a continuous basis. But then today's particular event will definitely be featuring a discussion specifically on digital interoperability in Nigeria, the way forward. This particular event will be exploring the success and challenges of data accessibility in healthcare, especially in Nigeria, where we'll be drawing lessons that can be applied to advance healthcare across the African continent as a whole. I'm very much pleased to inform you that this event has been hosted by the African Digital Epidemiology Innovation Network, that's AIDIN, right? And AIDIN as a network is a Pan-African community of public health experts, researchers, and so many amazing stakeholders who are leveraging the application of unconventional data and technology to improve disease surveillance across the continent. AIDIN as a network is an expression of Design for Health practice of the Co-Creation Hub. And then I'm very glad to announce to you that Co-Creation Hub is the largest Pan-African innovation organization that is basically dedicated to harnessing the power of technology and innovation to tackle various socioeconomic challenges across the continent. At Co-Creation Hub, we have a robust track record of over 14 years. And as an organization, we successfully pioneered various innovative solutions in various fields, right, including public health, education, governance, smart infrastructure, fintech, even as far as creative economy, right? CCO also as an organization, we directly invested over $10 million and attracted over $150 million in investment to various African startups. And I'm very proud to let you know that we have about 1,100 startups that can boastfully trace their roots down to CCO. And as an organization, we definitely have presence in about 4 African countries: Nigeria, Namibia, Kenya, and Rwanda. And our programs have cut across over 18 African countries in the African continent. Also, we have various thriving practices across the organization, and one of the thriving practices that is hosting this event, which is the Design for Health practice. Basically, at Design for Health practice, we are basically dedicated to tackling various healthcare challenges across the continent using innovation, research, stakeholder engagement, and technology. So our work definitely at Design for Health practice is to collaborate with these key stakeholders using design thinking approach to co-create solutions that leverage technology to address various pressing challenges. And it's a pleasure to invite to welcome everybody to this very groundbreaking event. So, I mean, before I go further, just to go to the next thing on the agenda, which obviously will be opening remarks that will be taken by one of our amiable managing partners at Co-Creation Hub, that is in person of Oluwaseun Adepoju. Hi, Oluwaseun, good morning. Can you hear us, please?
Thank you, Adefemi. I can hear you clearly. Good morning, everyone. And it's a great pleasure to welcome everyone to this session today. It's been a few weeks of planning and putting this together, and I can confirm that the topic of discussion today is one that is very important. It is very dear to our heart, and it's also one that healthcare professionals needs to have continuously. As we know, data is a foundation of innovation for new frontier technologies, and also decision-making in healthcare, and also gaining insight is very important, and data is the foundation of this. However, we've seen situations of issues of data, interoperability, where systems cannot speak to systems, data cannot go across a technology stack to another one, or from an institution to another. there's also a lot of concerns and controls on data, which one way or the other limits innovation in so many ways. And I'm very confident that we've brought together very seasoned professionals and experts who can speak to this issue, from experiences, from their work, from their track record in the ecosystem as well. So I want all of us to have an open mind, to have a very rich conversation, ask important questions, but also not to limit the conversation to this space, but also to continue to engage as professionals so that we can look back in the next 10 years and say there's been a lot of progress in data interoperability, especially in the healthcare and public health domain in Africa. So once again, welcome everyone, and looking forward to a great engagement and discussion, and also great learning from all our panelists today. Thank you very much. Back to you, Adefemi.
Thank you so much, Oluwase, for that very warm opening remarks. Right, so going to the business of the day, and I'm very proud to tell you that today's particular event will be moderated by no other person than the head of the Design for Art practice, and that is a person of Stephanie Okpere. However, before she comes on board, let me just give a quick rundown of who she is, and then just a brief bio. Right, so Stephanie Okpere is a digital art expert and a strategy management professional with over 9 years of experience, leading the development of public health technology innovations, as well as fostering collaborations among public health stakeholders. She has led the development, optimization, and adoption of country-level technology solutions, and has contributed to attracting project funding of up to $20 million towards improving health and nutrition outcomes across countries, especially in Africa. She holds a master's in public health from the University of Manchester, several certifications in disruptive strategy from Harvard Business School, as well as qualifications in leadership and management. She's been a recipient of several academic awards. Currently, she convenes the AED network and leads the Design for Art practice at the Co-Creation Hub, where she provides advisory support to startups and other key players within the art ecosystem. Ladies and gentlemen, it's a big pleasure. Please join me in welcoming Stephanie Okpere as she moderates today's session. Hi, Stephanie, good morning.
Hi, Adefemi, good morning, and thank you very much for that. I'll let you also go through the profiles of the other panelists that we have, and then I'll take over from there. Thank you very much. And hi, everyone, welcome to this session.
Thank you very much. All right, so the next panelist that we will be introducing to us is definitely no other person other than, sorry, just give me a second, the screen is coming up. A representative from the World Bank, that is in person of Mary-Liz Gojers, right? Currently, she is a senior specialist who leads efforts at the intersection of health technology and human development. In this role, she shepherds the bank's knowledge and advisory services to governments on issues relating to digital technology, innovation, as well as artificial intelligence. She led the team that produced the World Bank's flagship report, Digital in Health, Unlocking the Value for Everyone, which was launched at the G20 in the year 2023. She has a background in engineering, public health, data science, clinical nutrition, and functional medicine. She has, in the last decades, helped low and middle-income countries solve various pernicious human developmental challenges. Prior to joining the World Bank, Mary-Liz worked for various leading private sector and non-government organizations on large-scale health and education sector transformations, not just in Africa, but as well as Asia and Eastern Europe. Ladies and gentlemen, join me in welcoming Mary-Liz Gojers. Hi, Mary-Liz.
Hi, Adefemi. Thank you very much for the invitation to be here today.
Thank you very much. It's a great pleasure to have you join us, Mary-Liz. All right, so the next panelist that we'll be introducing to us today is a panelist from WHO, that is in person of Interoperability. Interoperability is a health system strategy expert with the WHO, working in the Nigerian country office in Abuja. She holds a first degree in pharmacy from the University of Nigeria, Nsukka, and a master's degree in public health from London School of Hygiene and Tropical Medicine. She leads work around health information systems, health research, digital health and innovations, working closely with the government of Nigeria and other stakeholders. She was instrumental in developing and implementing several policies, strategies, and plans in the health sector relating to the areas of expertise. Furthermore, she has led several efforts in the country of the rational adoption and the use of digital technologies to improve health and accelerate progress towards achieving universal health coverage. She is currently a core technical team for developing the national telemedicine guideline and contributing to the effort to establish a sustainable system for data exchange in the country. Nkeruka, good morning.
Hi, Adefemi. Good morning. Good morning to everybody.
It's a great pleasure to have you join us. All right, so our next panelist for today's event is another person apart from our representative from Corona Management System, who happens to also be the managing director, as in person of Dr. Chijioke Kaduro, who has been working for the past 17 years in public health program management. He has over 10 years of those working in public health in low and middle income countries. He is also a public health physician and holds an advanced degrees in public health, infectious disease epidemiology, as well as business administration. Dr. Chijioke Kaduro has worked extensively with digital health in Nigeria and in sub-Saharan Africa, helping deliver interventions to strengthen health information systems for polio, routine immunization, and the health system overall. Dr. Kaduro is currently the managing director at Corona Management System, an indigenous Nigerian public health research and consulting group, which has expanded into Kenya, Cameroon, Lesotho, Congo, Gambia, and Djibouti, and has also established account offices in the United Kingdom and in North America. Hi, Mr. Chijioke Kaduro. Good morning.
Hi, good morning, and good morning, colleagues. It's a pleasure to be with you on the panel today.
Thank you very much, Dr. Chijioke. All right, so the next person I will be introducing to us today is our panelist who's representing the Nigerian Institute of Medical Research. That is in person of Dr. Olufemi Amoro. Dr. Amoro is a fellow winner, is an award winner from the Peter Plot Postdoctoral Fellow, and also he happens to be the head of the Center of Human Virology and Genomics and the research lead of blood genetics and transfusion research, both at the Nigerian Institute of Medical Research, NIMR. He is an innovator and award-winning research scientist that has been researching the immunogenetics of disease. He conducts research in public health diseases with an interest in infectious disease and reproductive health. Dr. Amaro focuses on digital epidemiology, implementation research, host-pathogen interactions, carcinogen DNA interactions, bioinformatics, and computational biology as a tool for early and efficient medical interventions. Hi, Dr. Amaro. It's a great pleasure to have you here. I welcome you especially. Good morning, Dr. Amaro.
Yeah, good morning, Adefemi. Good morning, everybody. It's a pleasure to be on this platform too. Adefemi, you forgot to mention that I'm also a foundational member of ADIN. So I had to give my membership certificate. It's good to be here this morning. Thank you very much for being here.
Thank you so much for that, Dr. Amaro. No worries, your certificate will be given to you. All right, so the next panelist that will be introducing to us is a special person who is a person of Ayomide Owe. It's a great pleasure to have him here, especially just to mention that he just recently concluded his PhD. And so just to say that Ayomide's background is in medicine, public health, and product management. He has had experience working as a clinician and public health physician in Nigeria. He was a consultant on the Global Fund project for HIV care and management. He has also built different digital health products for Nigeria and other African countries. He led the team that built the first COVID triage tool in Nigeria and the first artificial intelligence-based recommendation system for both health insurance in Nigeria. He also worked with Boston Consulting Group as a product manager. He just rounded up a PhD in health informatics at the University of Illinois, Chicago, with a focus on AI and machine learning applications in healthcare. Hi, Ayomide. Good morning. Good here if you're speaking, please.
Oh my God. Yeah. Hi, Femi. Thanks for having me, and thanks to everyone for joining this session. I look forward to the discussions we're going to have.
All right, great. Thank you very much, Ayomide. And I think that's the last panelist that we have for today's program. And before we delve fully into today's program, before I hand over now to our moderator for today's event, I think it's just safe to say that during the course of the conversation, should you have any questions, please feel free to put your questions in the chat box. It will be picked up during the Q&A session, and we will definitely address your question. But then in the meantime, thank you so much for joining today's program, and then I will hand over down to the moderator of today's event, Stephanie. Good morning.
Good morning, Adefemi. Thank you very much for that and for just doing the introductions for this session. I'm sure our listeners and participants in this session already recognize that we have a rich lineup of panelists, experts discussing with us today. So first of all, let me say good morning to everyone. Welcome to this pivotal event. We are having a 4 roundtable series, which is actually focused on healthcare data accessibility in Nigeria and the lessons for Africa. And we have a special focus today on digital interoperability in Nigeria, the way forward. I'm honored to be here with these esteemed experts and leaders in the field of healthcare, data management, and digital innovation. So let me first of all extend my gratitude to all of you, our distinguished panelists, for making the time to be here. Your presence here today underscores the critical importance of this topic that we're about to delve into. To set the stage for our conversation, we'll be inviting Ayomide to give us a brief presentation. While we have him set up for that, I'll also just provide some context to our conversations as well. Today, I believe that everyone recognizes that data is the new oil, and for our healthcare system, accessibility and interoperability is fundamental. For Nigeria as a country, we have dynamic and diverse population. And for us to effectively manage and utilize healthcare data, data interoperability is no longer a question of just administrative necessity. It's actually a catalyst for a broader healthcare reform and improvements. We recognize that there are diverse systems and organizations that need to exchange and interpret data accurately and efficiently. As such, it's no longer a luxury. We believe that digital interoperability can pave the way for better patient outcomes, more informed policymaking, and a more resilient healthcare. We, however, understand that for us to achieve this, there are several hurdles, challenges, issues with technological disparities, data privacy concerns, and the need for robust, that we need to surmount, as well as the need for robust infrastructure and governance. Today, we hope to address these challenges head on by leveraging the collective expertise and experience of those gathered in the room, sharing insights, best practices, and hopefully identifying a roadmap for how we might chart the way forward, not just for Nigeria, but as an opportunity for other countries to be able to learn from the experiences, the opportunities, the challenges that as a country we faced on this journey as we move forward. Why Nigeria, you may ask? We recognize that Nigeria plays a critical role in Africa as one of the countries in the forefront of digital innovations. And we believe that by examining Nigeria's achievements or challenges, we can glean valuable lessons that can be adapted and applied in other countries. I think it's important to mention that we've seen significant interest by the government to address these issues. The setup of the Digital in Health, the 20-man committee on Digital in Health initiative underscores the focus of the government in this regard. And we've seen several states also express interest in action and also by their interactions with stakeholders to address this problem. As such, I encourage every participant here today to be part of this conversation. Like Adefemi has said, please feel free to leave your questions and contribute to the conversation. Once again, thank you. I'll quickly hand over now to Ayo to go ahead with the presentation and set the context for this conversation. Over to you, Ayo.
Yeah, thank you very much, Stephanie, for that talk and that speech on the significance of why we are doing what we're doing today, and bringing these different people together. So I'm just going to go briefly about on what this is all about and what we are looking forward to, and just sort of lay the foundation for most of the discussions that will happen today. So, today's focus is majorly on interoperability, but the larger discussion sort of revolves around access to healthcare data, across different areas. So, yes, I don't know if you can see my screen, but to just sort of give a background, the significance of healthcare data, sort of cuts across multiple areas around clinical research, population health research, development of tools for patient care management, research in the pharma, healthcare planning and management, and then for continuity of care. And so this sort of revolves across the multiple areas where you look at data accessibility for patients, data accessibility for clinicians themselves, data accessibility for administrators, and data accessibility for the government. So sort of cuts across multiple areas and multiple stakeholders in a specific healthcare system. Now, to sort of move a little bit back and forth, sort of need to talk about what interoperability means. It's a popular word right now. Everybody keeps talking about interoperability and how it's important for maximizing the data we get from the healthcare sector, and we use it in a much better and a much impactful way. And sort of I'm going to use the definition from IMSS, which is the Health Information and Management System Society, where they talk about the ability of different systems to be able to communicate together, exchange data, and sort of use the information that has been exchanged. You sort of take it much further and look at how multiple systems sort of integrate with each other. And as we have all realized, in this present age, there's this significant premium that is placed on data. And one of the places where one of the largest amounts of data is created very often is in healthcare. If you've seen clinicians, it's always about documenting, recording signs, symptoms, medications, lab results, and a multiple of data points that are collected about patients. So interoperability basically addresses how those multiple disparate systems, that are being used in different places or even in the same location, but across different departments, sort of integrate or interact with each other and exchange data in a way that creates a much holistic and a comprehensive picture of things for either a single patient, a single healthcare system, or a single disease, or even a very large population. Now, so to sort of talk about the Nigerian healthcare system, one of the things that has been sort of emphasized significantly across different fora is how there's significant fragmentation in our healthcare system. You look at how, for example, how payment is done, look at the tiers of healthcare delivery, look at private healthcare sector versus public, you look at even fringe practitioners, people who in a lot of cases are the people that regular Nigerians patronize the most. And then you sort of look at how there are data in different silos that do not speak with each other. And one of the things I remember, there was a session we had once, and someone was talking about how data does not exist on this particular thing. And one of the things that was important to mention at that session was the fact that that data actually existed. It was not just accessible to you or I mean, the person and I who were in that conversation. And then a couple of those data that needed to be sort of aggregated together to create a better picture were sitting in different silos because different organizations collected them for different reasons, for different purposes, which is like one of the challenges you have with donor-driven engagement in a lot of cases where your planning is not done centrally and it's not done mostly according to your own priorities. So this challenge exists, and it sort of revolves into data. Now, even before we get to the fact that data exists in silos, we have to sort of take a step back and look at how we really do not have, a good adoption of electronic health record collection, electronic data collection and storage systems. Most places in Nigeria still use paper methods to curate their data, to store their data. And a lot of the electronic data collection methods are donor-driven. You see, mostly in programs around HIV, TB, and cancer in some cases, as you may. So that challenge exists, and so that sort of created multiple challenges on how useful that data could be in creating a clearer picture of what is going on or what is happening across the country. And this is much the same for places outside Nigeria. So a significant interoperability comes into play when you look at the management and continuity of care. So one of the commonest things you see around is if you're seeing patients, is that patients move from point A to point B, and then they have to repeat tests all over again. It's almost like they're starting their care afresh, where they already have like maybe 3, 4, 5, or 6 years of history that is useful to the context of whatever it is they're going through at the moment. But that is something that doesn't really happen. So it creates a challenge of, offering patients the best quality of care that they should have. And then, sort of look at issues around, population health research and population health management, where the picture of, what really happens in a community, or what really happens across multiple areas isn't clear, because most of the data is coming from a very small place. And most of the data being used in evaluations coming from a very small place, or it's coming from a single source or different areas. And also integrating those actually makes a significant difference. And a very good example that I like to mention, which is something I've worked with, is the Epic HR system, which they sort of did with their Cosmos system, where they've integrated data from multiple healthcare facilities covering over 100 million patients across multiple healthcare facilities. So allows you to see a better picture of what those patients look like, what they suffer from the most, their medications and everything from a population health perspective. And it's used significantly for population health research across research institutions. Now, the other thing is that, like I mentioned earlier, sort of talked about this, but we have challenges of data creation, aggregation, and sharing in usable forms. The best way for you to transfer data right now in Nigeria is that a doctor sits down and writes a couple of pages of referral documents, sort of explaining some of the things that has been done, and in a sort of prose format. There's a lot of nuances lost, a lot of data lost in that process, and then maybe they give you your results, but that really doesn't help significantly. And then in the other cases where that's kind of granular data does not get past, we know that the DHIS2, where there's a population view that gets reported to local government and different levels, but there are a lot of nuances, a lot of perspectives, a lot of data points that are missing in that population view. And so, being able to solve the challenge initially, which is at the baseline of EHR adoption or EMR adoption, as you may, sort of goes a long way in the larger conversation about interoperability. You can't interpret things that do not exist. So solving that is like one of the biggest things that needs to happen initially. And there are multiple ways to solve that. Different countries do central planned. Different countries allow private institutions to sort of run differently. Depending on how things go and depending on the kind of system you have, there are multiple approaches that work in that regard. Now, the significance of that for data access sort of comes to the idea that having an interoperable system ensures that data you have is more comprehensive and more gives a clearer picture, and sort of offers more value and insight for clinicians and practitioners. And the other thing that also does is that these disparate data silos that are sitting in different areas that are not communicating with each other, having being able to interpret them ensures that you can put them together and use that to make a much better decision. Now, the idea of the concept of data access is much larger. I mean, it's the higher picture where can people even get to use this data? And it's not totally tied to interoperability in that sense, because even the data that exists, as they are not interoperable at the moment, are not accessible to product developers, practitioners, and to researchers who are trying to use those to understand concepts of phenomena much better. But interoperability sort of layers on that and improves the usefulness and the richness of that data. So that is where the concept of interoperability comes in for this specific regard. Now, I'm going to round up soon, but sort of the reason why we're talking about this specific topic is based on a couple of experiences I've personally had and a lot of people have had in trying to access data and use data for decision making. A very good example I like to give is the fact that we usually talk about the fact that Nigeria did very well when it comes to COVID, and we didn't record so many deaths, we didn't record so many cases. But the significant challenge is that the challenge there is that if you don't collect data, if you don't report data about something, then what you have is technically what you have. And relying on what you have when your data collection approaches are not well developed, not well reported, poor, can sort of skew the perception about what you're seeing. I sort of worked on a research that showed that the countries that had much better developments, much better data collection systems had higher debt. So you can sort of interrelate that to correlate the fact that when there are better reporting systems, you tend to have much higher debt in that regard. So there's a challenge that the fact that challenge exists there in the sense that the data for what happens really on the ground is not accessible. Like someone said, last month, we don't know what killed Nigerians the most last month. We have no idea because the data is collected in some way, but it doesn't make it to a stage where we can use it in a useful manner to make decisions. And then the other part comes to, as a researcher, I was working with a group, a sort of open source group. We're trying to build an AI system sort of help with anomaly detection in healthcare records. And one of the challenges we had for a long period of time was in getting the data we needed to build that system. Luckily for us, we had some sort of a team member who could help us facilitate access to some sort of data. But a lot of researchers in Nigeria do not have that sort of opportunity. If you need data to run anything, either you go and abstract from notes yourself, which is what a student from Illinois I spoke with did, or you buy the data, which is super expensive. So this sort of significantly limits research, it limits development, and it limits how well we can tap into, for example, the AI superpower, so to speak, that we have right now. Now, moving on, data is the lifeblood of AI. So if you don't have data, you can't really have very useful and usable AI systems. And as we see, a lot of Nigerians, when they are building AI systems, they rely on data from the US or data from cargo or at times synthetic data. The data from the US is open. For example, we have MMIC or ER shots that consist of data of their patients that have been made easily available to anybody who needs to be, and that has significantly accelerated R&D in those countries. And that is like a rate limiting step we have, especially in even making what is built elsewhere work for us. So moving forward, the challenge, like I mentioned, is that the rate limiting step, the challenges of models working for us, the significant issue around AIHR adoption that has limited the creation and curation of data in a usable format for research and development. And then the other idea about the expenses that sort of comes with the available options. Now, this is the big picture. The big picture shows the fact that building a much advanced and boundary pushing system relies significantly on open source. One of the biggest leaps in AI was sort of built on an open source open source innovation that was designed by Google. They built the transformer system and they open sourced it, and everybody sort of took that to an higher level. If they had not open sourced it, then I don't think we would be where we are and the level of advancement we have in AI at this moment. So one of the things that sort of comes into play is how can we sort of enable more open source systems, either for data. Even the most interesting thing is that when you look at EHR, most of the EHR systems used across the continent are based on open source models. You look at open MRS, which Lagos State government is trying to adopt right now. So these sort of the things that sort of comes up in all this conversation. And these are the things I sort of look forward to the fact that we're going to talk about today. Look at how we can sort of look at the interoperability of systems, even the creation of those systems initially, and how they sort of play in our goal towards improving data accessibility for Nigerians. And this conversation goes beyond Nigeria and goes across the whole African continent. So I will hand over to Stephanie as we start the session. Thank you.
All right, thank you very much. That's quite elaborate. Just also, bring us back to our conversations today. We recognize that data access is a critical and separate conversation. However, we consider the interoperability of systems as significant. We recognize that there are additional benefits. Sorry, excuse me. Please, can you confirm that you can hear me?
Yes, I can.
Right. While we recognize that interoperability can play a key role in ensuring continuity of care and how this is critical across board. One of the key focus for aiding is also related to data access. As we make these systems interoperable, how would access to this data be ensured? Today we have with us, as mentioned earlier, Marilis from the World Bank Group. I would also like Marilis to help us further establish the context, particularly as it relates to digital interoperability. What is digital interoperability? Why is it important, especially for African countries? Marilis, please. Feel free to take the floor.
Hi there. Yeah, Stephanie, thanks very much for the question. First, I would say, and it was very useful, the context that Ayomide provided. When we think about interoperability in health, the interoperability of health data is clearly absolutely essential, as Ayomide just illustrated. Over and above that, though, we need to think about technical and semantic interoperability as well as the interoperability of services themselves. In other words, what I'm suggesting here is that when we think about interoperability, the interoperability of health data is one component of interoperability in health, but we really need to think about interoperability in a more all-encompassing way. We need to think about it in terms of financing mechanisms, in terms of how people access services, in terms of the seamlessness between which people can switch, for example, between public and private sector service delivery in a given year. We know that happens in Nigeria. You know, someone might have private insurance, health insurance, but they might run out of benefits in August or September and then move over to the public sector the rest of the year. Or they may choose to access some services in the public sector and some services through their private insurance. And that interoperability is absolutely essential as well. To your second question, why is interoperability important? I think we have to always bring it back to the value that it adds to health systems and the value that it adds to people who want to improve their own health. In other words, value to patients, value to providers, value to health system administrators, and even value for pandemic preparedness and health systems resiliency efforts, as Ayomide described in his presentation. Back to you, Stephanie.
Thank you very much, Marilis, for that. So now that you set that context, and I like the fact that you touched on the importance beyond, being able to share data, but also how it impacts, systems, financial systems and things like that, and how it can impact patient care as well as administration. Looking at Nigeria, what would you say are the key strengths and limitations with Nigeria's current digital infrastructure? How can we assess where Nigeria is in this journey towards digital interoperability? Over to you.
I think it's always good to look at surveys and at assessments that have been done. And in this regard, there's an excellent tool called the Global Digital Health Monitor. I put the link in the chat if anyone wants to look at what Nigeria's specific results is, or if anyone wants to compare Nigeria to other countries in the region. If we look at that assessment, which is a tool that WHO will use in the future to look at areas where countries can strengthen their systems, you can see that Nigeria has made progress with regards to policies and creating policies for digital health. There's some work that's been done in terms of standards, already setting semantic and technical exchange standards, but that the areas where the country still needs to do some work is in the governance of digital health, is in implementing these policies and ensure that they are properly financed, as well as the health workforce. There was an assessment that our colleagues at the IFC did that suggests that there is a significant gap in digital skills, and that as we think about digital strategies and rolling out digital technologies in health, we need to make sure that the health workforce knows, trusts, and are keen to use these technologies, and that they don't see it as a threat to their jobs, but rather as a tool to augment the health services that they provide. Back to you, Stephanie.
Thank you very much, Marilys. You did mention the assessment tool by WHO, and it's wonderful that we do have with us here Inkiru from WHO, who have been playing a key role in supporting governments towards addressing digital interoperability in Nigeria. Dr. Inkiru, it'll be interesting to hear from you the role that WHO is playing, and also to understand what your experience have been, what have been the key challenges identified, and what progress have we made as a country towards achieving or addressing our digital interoperability needs.
All right, thank you very much, Stephanie, and thank you, everyone. It's really commendable that, again, we're elevating the discussion around digital interoperability. Well, for Nigeria and for the roles that WHO has played, considering the role of WHO in the health sector of the world, the role and its influence also spills over to countries of the world, including Nigeria. So in terms of the role, it's not just limited to what we have been able to do in Nigeria or what we've been able to do in the African region, but also what has been done at the global level that is impacting the work around digital health across the globe. So, but if I may be specific around this, WHO has supported in terms of answering the demands of member states across the world in bringing up a strategy or a roadmap, to help countries to be able to rationally establish their digital health systems. Currently, there is a lot of guide and standard, but I'll mention specifically the Global Digital Health Strategy 2020 to 2025, which provides the roadmap for countries to use and itemizes with the details all the enabling environment factors for digital health, including the issue of governance, including investments, including things like standards and interoperability, and an issue of digital literacy and what the application should be like. Now, if I want to bring it back to the region in Africa, the regional office has also articulated this to form the African roadmap. And then in Nigeria, we contributed to the development of the first digital health policy and the strategy to implement it. And also recognizing that the currency for digital health is actually data. On the data side, from the health information system, the framework, the strategy or the policy framework also for health information, we also saw the need to also do something there. So we contributed to that area. And now also tools, there are global tools that has been produced or developed by WHO and other stakeholders to enable countries to work in the effort to improve health using the digital technologies. Things like the Digital Health Atlas, which is a registry of digital intervention that helps countries to have like a landscape of what they have, which is kind of foundational when countries want to embark on health information exchange efforts. And that has been launched in Nigeria. Unfortunately, it wasn't success. Not that it's not successful, it's there, but not really being used per se because it is a tool for the government to use with support from partners. There are several global goods that's out there. There's the SMART guidelines that can enable countries to standardize the normal guideline for different programs in a way that it can be consumed by different softwares and actually leads to seamless exchange of data among several platforms. And then there are other standards. About 4 or 5 years ago, we supported the work around adoption of international standard organization standards, the ISO TC 215 for health informatics, which is expected to help the country in the journey towards interoperability and data exchange. And those standards are domiciled now with the Nigeria standard organization. There is also the issue of capacity building. In fact, currently, WHO, with collaboration with our regional office, training 20 health workers from the Federal Ministry of Health and some partners, in understanding how to plan digital health systems. Because we understand in the course of our work in countries that part of the mistake countries make is not because they don't want to do the right thing, but it's because they don't really understand how to plan investment, how to plan infrastructure, how to do the governance, how to have like a system-wide approach towards implementing digital health, and which in the long run affects the issue of enterprise architecture, enterprise planning approach and the likes. Thank you.
All right, thank you very much, Dr. Nkiru. You've touched on the extensive work that WHO has done, both at the regional level, global level, and even within Nigeria. You've highlighted significant effort made. I mean, developing roadmap, frameworks, standard operating documents. And I think all of these things are great, which also aligns very much with the feedback that Miralis had given us regarding the context in Nigeria. Frameworks exist, tools exist. There's also the need for improvements in workforce. How would you say that this has brought about progress, or what progress have we achieved with the utilization and implementation of these frameworks and tools in Nigeria? And what are the tangible impact outcomes that we're already starting to see based on all of these activities or all of these frameworks that have been provided within the country?
All right. I would say that progress and success is missed in the sense that while right now the understanding of digital health or the awareness that technology can actually take us to achieving universal health coverage, not on its own, but of course, aligning to processes, and bringing in efficiency and access and all that, that awareness is there. I remember before we started work on the policy and the strategy, there was a National Council on Health, which is the highest policy-making organ of in the health sector, as you know. It brought in stakeholders, commissioners of health, permanent secretaries across the states. And we pushed for a section on digital health. And it's surprising to see that a lot of these key players, they have interacted in one way or the other with digital health or an application, but they don't understand what it is. They don't call it what it is, And they don't also understand that they have the power lies with them to really make use of these things to improve the health of the people. So it was like an awareness and sensitization section, which now gave birth to the need to synthesize or engage these policymakers, implementers, kind of a multi-sectoral, multi-disciplinary group on what we need to put in the policy, where the policy direction or focus should be, and then a national stakeholder engagement at the regional level happened, and that was the basis for what is in the policy. Now, beyond creating that awareness and having one or two states taking it forward, taking the leadership, taking the power, strengthening their governance for digital health, and really making sure that maybe partners implementing in the states aligns to what they want, the context, and what a particular intervention is going to be used for. I would say that to a large extent, a lot of states and stakeholders, especially at the government or public sector level, have not really kind of embraced it well. And this I will attribute to the issue of the governance, in the opening remarks, you mentioned about the current political will we have in the health sector. This was not here before. While the previous health sector leadership, they are passionate about improving the health system and all that, we know, but the level of engagement or discussions or the elevation of discussions around digital health was not there. In fact, before this administration came, we were planning with the stakeholders to have like a ministerial briefing on digital health to just keep creating awareness at that level where it matters. Because without the political will, you can do little. Investments will be impaired. Whatever, even if you have the best strategy in the world, investment will be impaired, and investment has a direct linkage to infrastructure. The issue of partnerships, there are stakeholders that want to partner with the health sector, but when they don't see the leadership in the health sector, they fall back. The telcos, for example, may want to engage in corporate social responsibility and fund or help to improve internet connectivity in some areas when we work with them. But when they don't see that leadership driving this in the sector, where would they come in to invest? So when you look at it, you see that the bottom line was the issue of political will is at the level of that governance. And then also when you notice that because these things were lacking, people were just doing whatever they want to do. There's proliferation, there's chaos and all that, a lot of silos, coming out. It all is tied down, and then not being able to now use our strategy, use our governance framework as it was then to really coordinate and enable improvement and achieve what we really want to achieve in the sector is impaired. So that's why I say that the success is mixed. At least we have awareness and we have a few states really going forward with that. But the political will was lacking then, and now we have it. And I believe that that's really going to go a long way. So I think my feedback covers both what the successes or achievement have been and the impact so far.
Fantastic. Thank you very much, Dr. Nkirika. I think one of the key take homes from what you just said is that political will and effective stakeholder coordination is critical. So I'll be moving on to our representative from Corona Management System. We understand that Corona Management System is involved in the deployment of digital solutions within Nigeria. And as such, we would like to hear from your perspective, what's your perspective on digital interoperability, the stance of digital interoperability in Nigeria? What's the progress and how does it impact the delivery? Also, you can touch on what role CMS actually plays and how digital interoperability actually impacts the work that CMS actually carries out. Over to you, Dr. Kajiru.
And thank you very much, Stephanie. And thank you again, colleagues, for taking all the time to listen to us. I think that just in response to the points or questions raised by Stephanie, and building on some of the other conversations and points that colleagues have raised as well, I think that primarily the digital interoperability landscape in Nigeria is shaped by, going beyond the policy and the governance structures, is also shaped by what I would consider a bit of our body language around the data that we have within the health system. So a lot of our leaning continues to be on population-based data coming out of the health management information systems. And we need to come to a clear realization that the journey to universal health coverage would be impossible without name-based data systems for health. And so shifting to increasingly leveraging electronic health record systems and building out integrations between those electronic health record systems and population-based data systems would ultimately give us the platform for having the right data and building out the kind of analytics that would ultimately help us deliver value to each individual patient and to the population at scale. That shift needs to happen, and it needs to go beyond just the policy documents, but also to how we design, deliver, implement, and also monitor the different programs and interventions that are happening across the country. And when you then juxtapose this against a system like Ayomi had flagged that is clearly fragmented, you then realize that the journey really needs to start and needs to start quick. And in the context of fragmentation, the way we've looked at it through some of the assessments that we've done as a team, we've identified that at a subnational level in health in Nigeria, for a commissioner for health or a governor to be able to make decisions about health within that state, they need to interface with about 94 different information systems. And that's realistically not a way to make a decision for anyone, right? No matter how good your interests are for the people that you're serving. Right. So there needs to be a real conversation about the fact that we are dealing with about 94 different systems, some of them purely paper-based, some a combination of paper and digital, and some of them exclusively digital. And across these 94 systems, we would consider electronic health records as just one system. Now think about all the different hospitals with all the different electronic health records that they've got deployed, operating with different standards, and not exactly getting the right oversight to be, again, integrated. And all of that just creates a system that is even much more difficult to manage than we can see. But of course, like Nkiru had mentioned, there is political will at the moment demonstrated in the sector-wide approach and the prioritization of digital and health towards ultimately changing the narrative around these conversations. And it's then important for us, all of us, to see how, as stakeholders, we align with that sector-wide approach, we prioritize digital and health, and we start to build out our different efforts and solutions to ultimately achieve this agenda as is. Now, if you think about that within that space, the roles are very different for different stakeholders, whether you're government from the Ministry of Health or other line ministries that are, again, relevant to the conversation around digital or health in general, or you're a bilateral or multilateral agency who's providing funding or some technical assistance for the deployment of these systems. There needs to be that collaborative alignment between everyone with one agenda, one objective, one plan, and ultimately one way of monitoring that plan to deliver a stronger and more interoperable, digital system within, the health and healthcare architecture as is. Now, there are also private sector players, including healthcare service providers as well. How do we start to engage with them around the patient bill of rights, the standards that are required in their deployment of electronic health records, how we create a system where these different electronic health record systems can, whether it's through APIs or through other linkages, start to communicate with each other within centralized systems. And how do other private players like our team at Corona, how do we make sure that we're facilitating and building out systems that actually support and advance that cohesive agenda, rather than everyone splitting up and fragmenting and going in multiple, different directions that ultimately do not serve our broader best interest. And in the context of researchers who want access to data, how do these researchers come in as partners to the health system before even the data is available to shape the kind of data that is collected, to be there to help advance broader health system strengthening, so that the owners or custodians of data see these researchers as partners in progress, rather than seeing them as pure consumers of data when the data is now ready, available, and good to go as is. But there's also the issue of etiquette and integrity in our handling of data. How do we as researchers also ensure that when we have access to data, we're utilizing it for the reasons for which we have sourced the data? We're not commercializing it in unilateral pockets without partnership with those who are ultimately custodians of that data as well. I think that, again, as stakeholders, we've got all of those different roles and responsibilities that need to come together if we're going to be able to improve our data systems, as is. And there's also a role for civil society, both in terms of ensuring that these data systems ultimately protect the interests of the patient and the everyday people as well. I mean, we do need to have that kind of aggregation of different stakeholders with different interests all converging to ensure that we're able to actually advance digital interoperability within the Nigerian health system. Thank you, and back to you.
Thank you very, very much, Chijioke. I think you pulled a lot of information into that feedback. And you've also highlighted the role of the various stakeholders. You talked about even patient education, why they need to understand their Bill of Rights. And a whole lot you shared there, very interesting. We've talked about some of the challenges as it relates to governance, and WHO and World Bank Group has given us a perspective as to where things are at that national level. And I like the fact that you've broken it down even as beyond government to some of the various stakeholders and the role that we can potentially play. It's interesting to see how you see the role of researchers, not just as consumers, but as a partner in the entire journey. I'd like to get back to the World Bank team, and Ayo and Dr. Amao, you're still very much part of this conversation. We'll get into the research elements very soon. And I'm going to come back to you, Chijioke, very soon as we discuss data utilization, data privacy, and ethical consent. But coming back to the World Bank team, I know that you've been, beyond Nigeria and from the global perspective, digital interoperability is a common conversation and interest. In short, it's one of the keywords that's been used mostly this year in almost every digital health related conversation. I would like to know, from your experience so far, what successful models exist for digitally interoperable health systems, especially in developing countries, and what can Nigeria, and by implications, Africa, learn from those models or systems that have been successful? Over to you, Mary-Liz.
Excellent. Thank you, Stephanie. I just want to say I'm really enjoying this conversation. There are so many, the golden threads running through the conversation is really, really coming together. I think the first thing that I would say in response to your question is that other developing countries that have been successful in tackling this digital interoperability have had two things in common. The first is actually what was just said about political will and governance being really strong. Without that political will, it is not going to work. And there I can think of Rwanda as well as Kenya, that's building a health data superhighway, as they've referred it, as other comparative countries in Africa that Nigeria may be able to learn some lessons from. And as you've said, the current political will in the country is a really strong foundation to build from. Second, I would say that the second thing that countries that have been successful have had in common is a real focus on the patient and not a focus on providers. It doesn't mean providers are not important, but if we're all as different stakeholders coming together to say, how does the health data that I have in my service, in my business of either financing healthcare or financing service delivery or implementing health services, how does that come together for patients? And then the third thing that countries have had that have been successful have had in common is to focus on value and focus on the pernicious and intractable problems in healthcare and prioritizing those technologies that can solve healthcare problems and not think about digitalization or digital technologies as the end, but really a means to an end to solve pernicious problems in healthcare. You know, if a person travels from one part of Nigeria to another, they should be able to access their diabetes medication or HIV medication or any other medication that they might need. Providers in different states, in public and private sector, should be able to have a complete picture about one person's health status. And that can only happen if we have interoperability. I will mention two countries, India and Indonesia, that are both large, federated countries with federal government systems that have been successful in doing this. You know, 94 information systems in Lagos is a lot. Indonesia was able to integrate over 400 health information systems in a period of just 18 months. This does not need to take a decade to do. We can do this if the leadership and the political will is in place, if there are common standards that we can all adhere to, if the government builds and governs the health information exchange, and then technical decisions such as centralized data in a data warehouse versus federated distributed data exchange systems. There are many technical decisions that need to be made along the way, but if those three things are in place, we see that countries can be successful. Thank you.
Thank you very much, Mary-Liz. Really interesting points. I'll come back to them at the end so that I can maximize time. But I wanted to know what considerations you think that countries need to make towards ensuring sustainability of these systems and of these systems. Please go ahead, Mary-Liz.
You know, I would only make one point here, and that is around financing. You know, when we talk about digital health, because it's usually people who are interested in technology who lead these conversations, the conversation we're typically not having is a conversation around financing. For example, there's a pregnant woman who receives an AI-enabled ultrasound administered by a community health worker as part of community health worker visits. Should that service be reimbursed by a health insurance scheme at the same rate as a pregnant woman who receives antenatal care service without AI-enabled ultrasound as a part of that service? I think we're not having these conversations, right? We're not talking about, ICD-9 or, health financing reimbursement codes that includes digital services. How does that play out? Who finances the health information exchange? These things are all typically, and we need to consider these early on, not just, I think our conversation sometimes exclusively focuses on interoperability and semantic standards and exchange standards and so on, syntactic standards, FHIR and so on, of exchanging data. These are important, but we need to also think about how this is going to be financed within the country's health financing mechanisms. And countries that have been successful have tackled this head on from the start. Thank you.
Thank you very much, Marilis. It means, therefore, that if we haven't started discussing the issues around sustainability, especially as it relates to finance, then it needs to become a key issue for discussion and alignment as soon as possible. And this will be, one of the last questions I would ask around digital interoperability itself as we form the World Bank Group, as we move our conversations a bit more into some conversations around data access and things like that. Dr. Kajuru talked about the roles of private and public, private sector, in this whole conversation. And Dr. Nkiru also highlighted that government needs to take that leadership before the private sector can really come in and play a role. How does the World Bank support public-private partnership, especially as it relates to this conversation in Nigeria? Are there ongoing investments? Are there initiatives that are being supported? And what would you see are the key ones to look out for those who are on the call?
Yeah, I mean, I think, the World Bank supports both financing as well as technical assistance in digital health in multiple countries, both through our private sector arm, the IFC, as well as the development financing that we provide to countries. I will say that in terms of the latest health reforms, there are discussions underway at the moment about how the World Bank could support those financing mechanisms. We also have existing programs in the IFC. And, if there are private sector organizations that are interested, that's always an avenue that they can reach out to. I will also say that part of the support to the private sector involves the technical assistance on interoperability, health information exchange establishment, as well as the conversation around financing, right? Because whether it's public or private sector, we need to get financing right. And I believe that if we get interoperability right, we immediately create avenues for the public and private sector to work together, regardless of whether software is open source or not, right? Because if we can have open access to data and there are guardrails and good governance on how data is exchanged, then systems in the public and private sector can work together, even if not all systems are open source. Over.
All right, thank you very, very much, Marilis. And I'll just come back to Dr. Kajuru. Marilis has touched on opportunities as well for private sector, for collaboration, and some of the potential financing mechanisms that are currently being discussed and can be looked out for. I want to take us back to data itself and then data use, as well as data access. There's a lot of conversations around policies relevant to data utilization, issues around data privacy, data security. I would like for you to shed some light on ethical considerations surrounding data privacy, data security, especially as it relates to assessing healthcare data. Dr. Kajuru, please.
Thank you very much, Stephanie. That does feel like a bit of a complicated question, all things considered. But I think that what's important is that, first of all, there is a global data protection regulation, GDPR, that essentially sets the tone on a global scale for how we access and utilize data. There's also a national data protection regulation in Nigeria as well. And I think that for starters, it's very important for all of the colleagues who have to work with data to be very familiar with some of these data protection regulations, because as you well know, an item might be under the radar, but I mean, ignorance of that regulation is not going to be enough in the context of a breach or some other security lapses is. But it would be important for people to be very familiar with those regulations. Now, I think that there should be, very key considerations, and I mean to say this from the lens of a physician, that we primarily have to endeavor to do no harm in our use of data, whether in terms of how we collect data, how we analyze it, and how we ultimately use it for decision making and action, across the health system. And so that has to be a fundamental principle that shapes our utilization of data. But we do also have to imbibe a very high level of integrity and etiquette in all of what, or ethics in all of what happens with that data. Now, there are a number of issues regarding, applying for data access with a particular purpose in mind, and then pivoting to use that data for something completely different. I think that these are all issues that within a strong governance structure will be very clearly addressed. But I think as a consumer, it is very important to be familiar with the regulations. It is very important to sort of stand above board in your own, personal ethics in the use of data and abiding by extant regulations as is. But ultimately, it would again always come back to the governance systems that are in place to provide the general oversight and stewardship of how people consume data. I think that we can all agree that impunity would always hold sway if there isn't strong regulation, all right? And it's not just regulation on paper in terms of having the relevant documents, but it's implementation as well. And I think all of these are critical to create an enabling environment that then imbibes trust and allows people to share data a bit more freely within the defined standards and parameters for exchange of data. And if we always put the patient first and have that clear recognition that any access or use of data has to be designed to benefit the individual patient and the population at large, then we again are able to create that environment within which we can work better, access and use data as is needed. Thank you. Back to you.
Right. Thank you very much, JK. We're talking about data privacy and data ethical concerns, especially as it relates to the use of data or access to data. I'd like to shift or beam our light at this point on Dr. Amao, who is from NIMA. Would like you to highlight as a researcher, what is the biggest challenge assessing and utilizing healthcare data in Nigeria? Dr. Amao, please.
Yeah, thank you very much, moderator. I must say that is a very interesting topic we were discussing, and I've learned a lot from the previous speakers. Again, before going to answering that question, because NIMA is a government agency, and then I need to bring in to the hearings of participants here what NIMA stands for. This I take as a practice because many people seems to be held when you say we have NIMA. So NIMA is Nigerian Institute of Medical Research and is the foremost medical research institution saddled by act, by law in the country, with responsibility of conducting research into the use of public health interest. This means that the product of our research is basically in the public interest. And because the term public health disease is the broader term, we collaborate with several stakeholders, including both within the health sector and outside the health sector, within the country, outside the country. Having said that, I must say that many people don't even know so involved in the use of
Dr. Amao, I think we're losing you. You're coming in and out. Can you hear? All right, it's clear. Go ahead. Go ahead. Yes, we can.
Saying that, as many people also do not know that NIMA is involved in digital health research, and I'm curious, at least in 2021 at the Nigeria Telemedicine and eHealth conference, I guess we met at that place. And then since then, I've been trying to get the attention of WHO. Now you're here, please know that we are willing to support those challenges and to see how we can get involved in those challenges you are facing presently and bring it to the limelight of Nigerians as far as the policy that is on grounds are. So to the question, what our challenges, I won't say is my challenges. NEMA as a whole, yes, we have access. If it's to do with access to data, because basically all the primary institutions, secondary and tertiary institutions in all the 36 states of the country, including Abuja, we have access and we collaborate together, we work together. But what has not been said is, having access to that doesn't mean it's digitally collected. And that's where the issue is. The problem is you see the data, but it is not of use to you because they are manually collected. And again, the problem is with that manual collection is that most of the time they are incomplete data. So you have the data, but it seems not to be useful for the purpose you desire the data for. So that challenge, that's one of the big things that is our back as an, yeah, some of these states have some backings of then donors like Cho, but it does not cross. So we have some states that have electronic and data record. But again, those we find difficult because the handshake between records is also difficult. The platform for they have the same purpose to achieve, but the platforms differ. So because these platforms are not the same, you find that information differ. And I think this is because it is not a platform that is indigenously. So the intention of the donors or the people that drive those platform is only what is being fulfilled. So eventually we find out that it does not fit the narrative, at least as a whole. So it's also a big challenge. Again, another challenge which I will tag because what we call data colonialism is a problem. You see, some people have this data electronically, and then you find it difficult to access because they feel they have the sole ownership of the data. These data were the use of the citizen. And so it's a big problem for us in the research sector that we have these difficulties. Yes, what is for us to say we want to generate our data ourselves? Yes, we have data that is being generated even within the institution, but because research is broad, there are several things that crop up, and then we are not we don't want to even be the only focus of the government or the donors. We know that it has to spread, but what we are looking at is what the question will be now, how do you now ensure that this data colonialism is addressed, that we have that relax a little in the use of, yes, Dr. Chijoke actually agree with his concern on ethics and the use of data, and then the fear of the data is being commercialized at the end of the day, or to drive the career of the researcher alone. But in the researcher's career will have to be driven by the effort is put in on ground. But for us as a research institution, that is not the focus. Focus is to how do we influence the policy. Most of the policy that is not being embraced, that is not being implemented, is because most of the time the tools were not tested within, and then it's like we have it being used in the US, and then we felt it's good there, and then we are bringing it to the ministry, to the policymaker. Yet this has been used so good, but indigenizing, how about making the local content, introduce the local content into some of these platforms and the policy that is being brought into the country. These are the challenges that I think, as a researcher, has been in effort in at least delivering our mandate, at least to the fullest, to the people of Nigeria. Thank you.
Thank you very much, Dr. Amal. That's very extensive, from data and paper-based data collection concerns, siloed systems, issues around data colonialization, which also, drives us back to our conversation around why systems need to be interoperable, while access to data is very, very important. And so I would ask the next question, Dr. Amal. You've talked about the fact that we're using paper-based tools still in some quarters being a challenge. I would have talked about, tell us a bit more about the role of technology and innovation, but I think you've also highlighted, some of the disadvantages of those database tools. So I would move quickly to our next question because of time. And my question would be, from the perspective, seeing that you represent the government in this conversation, what would you recommend as the way forward? How can we address these concerns that you've mentioned? How can we ensure utilization of technology, innovations within the healthcare space? How do we encourage the use of digital tools? But more importantly, how do we encourage a more data interoperable system within the healthcare space and improved access to data?
Thank you very much again. Yes, I must say, and I must admit here that technology is also expensive, very, very expensive to some extent. And this is one of the reasons why it seems that not in every except in every of the hospitals or facilities that we have around us. Again, I must commend the efforts of the government and the donors. One challenge that I think could help is education of personnel. Sometimes it's not the absence of this technology in those facilities, but the ability of the personnel to want to put it to use. To maybe this is going to replace me if it is much, much easier, I don't know. But from our own findings is that some people that is placed behind this desk and to operate, to generate this data, they are yet not willing to go with technology. They have the computer, they have the software on the computer, but the data is not being inputted. So then this need for education and more awareness of the importance of technology, what it will serve at the end, how it's going to make their work easier, not taking their work from them, how it is going to help even the client, that's the end user, to have a stress-free service within their facilities. I think those are the things that I think we need the government to put in place. Again, there are policies, I can tell you, but implementation is also a little bit difficult. So how do we gather a willing that could drive implementation of some of these policies that will ensure that if a facility in Lagos is using health record appropriately, at least 90% of their data is, what about the facility in Jigawa? How do we ensure that there is a level playing ground for these personnel to be able to adapt to the use of technology? We can't, this is 2020. Nigeria cannot afford to be speaking the way we are speaking today. We need to impress it on those behind the policy, those driving the policy, to also consider how they will put these human resources in the picture, not just dropping these tools, technology tools, they're not just putting a policy in place. How do we bring their interest in the use of technologies? Thank you.
Thank you very much, Dr. Amal. The role of the personnel who utilize technology tools cannot be undermined. We must ensure that we build capacity, we address needs, we address every fears regarding job security, and that we strengthen our approaches towards the implementation of already existing policies to encourage compliance. Thank you very much for that, Dr. Amal.
Exactly.
Are we moving forward quickly to Ayomide? You've raised concerns from the presentation that you made earlier regarding issues around equitable data access. You mentioned researchers finding it really challenging to access this data. And Dr. Kajura said, you know what, don't think about it just as a consumer, but think about it end to end. What role would you play to support in encouraging digital interoperability? However, my question to you is, how can we bridge the divide? If equitable data access is still a concern, what can be done to ensure that everyone can have access to data? Ayomide, please.
Yeah, thank you very much, Stephanie, and thank you very much to all the other members of the panel that have, sort of made explicit and very comprehensive submissions on this topic. And the way I would approach this question is in two ways. So one is I'm going to approach it from the perspective of a researcher, and then I'm going to address it from the perspective of what I would say the primary person in an healthcare system, who is the patient. So for the patient, equitable data access, so to speak, goes around the issue of how they can have access to their data, which is something that has been a big conversation for a while. People have been talking about personal medical records and a patient sort of owning their data or not. And this is a big challenge that we have in Nigerian healthcare system, which I've seen in clinical cases in which technically the hospital refuses for some reasons to release data to the patient because they need it for, the patient is trying to move from one facility to the other, and the hospital for some reasons refuses to, transfer that needed data to the patient so the patients can move ahead with their care somewhere else. And, these ab initio, this is like illegal. But the problem is that we have a challenge of, the patients not having where to sort of seek recompense in that situation. So it does exist. There's a consumer protection commission, but a lot of people have no idea that they can file reports or file complaints with that commission to ensure that area care facilities sort of adhere to how things should be done. There's this funny thing we used to say back then that the case note belongs to us, that doesn't belong to the patient. There's some truth somewhere in there, but the patient has the right to request and access their data when they need to. And this is made more difficult because of using the paper method. But using an electronic method can sort of reduce the friction in that regard, because in that case it means that someone does not need to maybe make photocopies or sit down and duplicate forms or write forms and things like that. You just need to either print or send through email. And I've seen that happen a couple of times. I've seen people send mails to a specific organization and they send their records to them. So the idea sort of goes back to the concept of us having more electronic methods for collecting data, and then the idea of interoperability, in which it makes it easier for you to transfer your data from one place to the other when you need to either change care or continue your care. Now, the other aspect of the equitable data access that comes in is the fact that if we do not have easy access to data about a specific group of people, then it's difficult for us to, in a way, make the best decisions that would be most beneficial for them. And which is why, having access to open data in that regard, which sort of addresses the other part for researchers, is very important. For having access to open data ensures that, researchers do not really have to jump through hoops to access the data they need to understand the specific phenomenon, understand what is happening in a specific community, or be able to make plans and predict in the future what could happen for a specific community around a specific healthcare phenomenon. So that equitable access, in my view, for researchers and for clinicians and even for patients, because it goes all the way back to them. The essence of research is to see how we can understand diseases better and make better decisions for patients. So that goes back to the idea of open data. Now, we have this Freedom of Information Bill, which, is sort of like a minefield that doesn't really go well. But for data, if those data are made open and nobody has to sort of know someone in a specific place for you to be able to access data, or sort of have to pay someone for you to be able to access something, and it makes it easier for people. For ideas are, like someone says, ideas are like even distributed, but opportunities are not. So someone somewhere can have an idea about something, and can sit down, get the appropriate institutional review approval and ethical approval in that sense, and then conduct that research. And so the thing is that life-changing research can come from anywhere. But when we limit the access of people to the data, they need to make those decisions. They need to conduct that research. Then we limit the level of innovation we can have. We limit the level of insight we can get from multiple people. So going back to what I was saying, we need to sort of start looking more towards open data, especially for public data that sort of affects that sort of generally publicly generated. One of the things I saw recently is that Switzerland just mandated that any research or data that is collected based on public funds and sort of run by the public should be made openly accessible. Where I am, if I need to sort of understand what is happening in a specific local area, in a zip code, a very small area, I can easily go online right now and get some sort of, there's a dashboard that I can easily click through to understand what is happening. I can even download the data. So I don't need to sort of jump through hoops. So, equitable data access would be a better thing for the community when we sort of look more towards opening access to the data we have, the data we generate, to sort of make better decisions. Yeah, thank you. Over to you.
Yes, thank you very much, Ayo. We're gradually coming to the end of this session. We're almost at time. And so I would like to say to the participants, this is a very good time for you to put your questions in the chat box. If you have any questions and you haven't documented it yet, please do so in the chat box, and then we'll take that very soon. But before we wrap up this session, I would like to go over all our speakers one after the other and just ask this final question. What concrete recommendation can we make towards ensuring that we establish and accelerate digital interoperable systems across Africa using Nigeria as a case study? I know we've talked about several things. If there's just one key message that you want to ensure or key action that you want to see stakeholders, any of the stakeholders take on as soon as possible, please feel free to emphasize. So I'm just going to go around so that we can get, final recommendations from each of the stakeholders, starting with Marilis, and then we'll go over to Nkiru, and then Dr. Kajuru, and then Dr. Amao, and Dr. Ayomide. Over to you, Marilis.
I think that the key thing is to focus on patients and their health, and everything else falls behind that. If that is the main focus, I think Nigeria can be successful.
Thank you very much, Marilis. Dr. Nkiru? Nkiru, can you hear us?
Yes, I can.
Okay, please go ahead.
For me, I think the lessons should be for any country that want to go this path, to think about the strategy, have a good strategy, which will, I think I said it earlier, will enable the investments, will enable a lot, and that also leads to the issue of enterprise planning approach, thinking for the future, thinking widely, and not just like sitting in a corner and deciding and planning what could happen, thinking for the future also, and also having a human-centered approach for whatever we want to bring in, for whichever data systems or digital systems that we want to be part of. How does it really align to the processes or to the workflows that is existing? So it doesn't cause an aberration, because any aberration affects the use, of that, whether for a provider or for a client or for the health systems.
Thank you very much, Nkiru. So the next speaker would be Dr. Kajuru. Please go ahead.
And thank you very much, Stephanie. Just building off of the recommendations from Marilis and Nkiru, I think that my primary recommendation on this would be that Nigeria as a country should also be comfortable starting small, subnational geography by subnational geography. Whilst it is great to get digital interoperability built out countrywide, we've seen many conversations stall purely on the premise that we're waiting until we can do it at scale for everyone, everywhere.
Right.
And I think that reality is just sometimes becomes a hindrance and then becomes a bit of a weight that we can't lift ourselves out from. So I think that would be my additional recommendation, to say, let's be comfortable starting small and let's build out from there.
Thank you very much, JK. Dr. Amao? Any final recommendation?
Can you hear me?
Yes, loud and clear.
So taking from Dr. Kajuru talked, I would say again, even the ones that are inexistent, let the policymaker ensure that there is handshake between those technologies being deployed. And second is education is very key and important. Education on the safety and confidentiality of information, education on the fact that it will not render human resources useless, and education that it will lead to customer satisfaction. Thank you.
Thank you very much for Dr. Amao. Over to you, Ayomide.
Yeah, thank you very much. So to just sort of piggyback on what everybody has said, I think where I would come from is the fact that as Dr. Kadiru said about starting small, one of the important things for us to do as a nation is to sort of look into the future and sort of set standards that the people are starting small need to adhere to, so that by the time we're trying to aggregate, eventually, you don't have to go through the process of working through multiple systems that might not eventually talk to each other. So we need to set those standards, and then the government sets the standard, regulates, and then provides funding. Because like someone asked in the chat, one of the things that helped adoption and sort of integration to a certain extent, not significantly, is how government steps in to sort of foot the bill for some of these things as public goods. These things might not make money. For example, health information exchanges are expensive to maintain. And some of the ones they have in the US are shutting down because the grants are done and the people who own them can maintain them. But if the government steps in and sort of maintains them as a public good, then the benefits would not come financially. They would come from the effect it has on population health and development for the people. And then the last thing I would mention is that, as someone mentioned, there are private ways we can sort of come in, and which is one of the things that I'm working on with Stephanie, the CC team, and we're looking to work with NIMA on is how we can sort of create a first of its kind open data platform that grants easy access for anybody that is doing R&D or building AI systems to easily access patient level data to sort of work on the systems. It's something we've been talking about for a while, and it's something we hope to take forward, and something we look forward to working with people on this call and other people in the audience with to sort of make it a reality. It's going to make a difference for Nigerians, for Nigeria, and then even for Africans as a whole. Yeah, thank you very much.
Thank you very much, Ayo, and thank you to each and every member of this panel and every discussant we have here today. Thank you so much for sharing your insights. We've definitely learned a lot. We'll be moving over to the Q&A session at this point, and I'll be taking the questions on the chat. If your questions specifically, you're expecting response from a specific member of the panel, please do indicate in your question, and then we'll address accordingly. The first question I'll be taking here today is that from Regan Roland. He says, question for Ayomide: is it possible to get a research access to working systems like Epic Cosmos or any other system that could enable a private company like mine compare models and processes?
Yes.
Would you want to take that right away, or do you want me to go over the question again?
No, I think I can take it right away. So for Epic Cosmos is a product of Epic. Epic is a private EHR company, and for you to have access to Epic, you need to originally have institutional access. Maybe your hospital is a client of Epic and they're using Epic. So if you do not have that, the way to go about that is to look for a researcher in an hospital that uses Epic, and then partner with them and fund a sort of what we call an industry-funded research to sort of have access to Epic Cosmos. But on the other hand, the Epic Cosmos is mostly for people in the US, and except you're bidding for the US, I wouldn't say that is what you should be looking at. What you should be looking at would be the counterparts in Nigeria. And not to sort of plug in again, the reason why we're trying to build the open data system is to make it easier for private individuals, researchers and regular people like you and I to have access to be able to test your assumptions, build those models and compare processes, without having to jump through the hoops of, going through multiple processes or paying a large amount of money for you to get what you need to do. So it's one thing we're working on, but something we hope to be able to achieve soon. Thanks.
Great, thank you very much for that response. I can see that Marilis has been doing some work in the comment section to really respond to a lot of these questions, right? Thank you very much, Marilis. That would definitely save us some time. I am unable to see any question at this point that has not been responded to. And so I will move from this section if there are no further questions. I can see very beautiful comments, but I also know that everyone on the call has access to the chat, box. So please feel free to look in there. There are very interesting things, conversation also happening there as well. But thank you very much. We're glad we're able to provide the platform for those interactions to be happening at the moment. Yeah, thank you very much. And so I would at this point, I would like for us, we're gradually coming to a close. I think it's very important as we wrap up this segment to just reiterate some of the critical points or things that we've learned from this conversation today. And I'd just like to highlight some of those things and, some of the key learnings or take home for me, hoping that that will be the same for everyone else on the call. And I like to say, if you didn't get anything from this session, definitely you should hold on to something from this end. So we talked about the importance of political will, the importance of coordination, and I did see in the comment section there some questions around even coordination for the various organizations involved in championing digital interoperability and the work that WHO is doing in that regard. We've said that regarding data, there's actually a body language that we should adopt. There should be generally a shift from a population-based focus towards a name-based focus as a way of ensuring that end users are, centralized and their benefits are centralized as we look at digital interoperability. So we should look at that intersection between the use of EMR and data within population database to actually allow us to make effective decisions for the population. And that this should inform how we deliver, monitor, and implement our projects. We've identified across various speakers the relevance for capacity building for the health workforce, the need to address certain concerns and myths around the loss of jobs and the importance of technology. We've also identified that there are the system is polarized. One of the speakers mentioned, the existence of about 94 systems, I think he mentioned within a state. And it was interesting to hear from Marilis that in Indonesia, there were over 400 systems and these were integrated within a duration of 18 months. This tells us that this is achievable and that Nigeria, as well as other African countries, can also achieve the same feat. We've highlighted that it's very important for patients to understand their rights as it relates to data access. And we've also highlighted the importance of open data tools. In addition to that, from our speakers have highlighted the presence and existence of certain strategies and policy documents, frameworks as well as roadmaps that can help us as a country navigate through. And it's very important that we start to consider implementation and compliance critically. Another thing we highlighted in this conversation is the need to think about sustainability from the outset. And one of the speakers mentioned that we need to think about the financial models being deployed in the development of these systems and how they will be sustainable in the long run. Those conversations need to start happening right from the onset. And if they haven't started yet, they need to start happening right away. We need to keep our focus on the patients and their benefits. We need to recognize that technology can help us solve significant problems and to emphasize the need to utilize technology. We also highlighted some of the data protection regulations, and we mentioned that the focus of stakeholders should be on ensuring integrity. And that is that data is being utilized for what it's meant to be utilized for, and that our focus remain on doing no harm. But that also we should ensure that we familiarize ourselves with the data protection policies within countries. We've also highlighted the fact that although paper-based data access is a problem, siloed systems is a problem, digital interoperability can help us solve some of those challenges. And finally, open data access can actually help researchers carry out more holistic analysis, help us better predict diseases, and also help us better manage our health as a country in Nigeria, but also across Africa. At this point, I would like to say a big thank you to the speakers today. We've learned a lot. It's been amazing, sitting on this call with you all and really learning from your experiences. Thank you so much for making the time. To our audience today, a big thank you to you for also sparing the time to be part of these conversations. We encourage you to share this information within, your work networks. The link to this video will be available on LinkedIn. Please feel free to share the link to other to persons within your network, and to continue the conversation around the need for data interoperability in Nigeria and in your various countries, be able to share information about what actions various stakeholders can and should be taking at this point, and to also be able to, collaborate in whatever way possible with other stakeholders towards ensuring that we achieve the overall goal of ensuring digital interoperability in Nigeria and Africa, and increased and equitable data access across the continent. Once again, thank you very much for your time. As we progress in our conversations, the stakeholders we have today on our call are important, very much important to us, and they would definitely play a key role in our future conversations and actions going forward. We do not intend for these to just be conversations. We also want to be able to identify actionable steps and what commitments can potentially be made in this direction. And so we're working with the stakeholders on the call, but also with every participant who would keep you abreast with the progress that we'll be making towards achieving this our goal. Please also be on the lookout. We have about 3 more series to go on this topic. We welcome you to follow us on this journey. If you are yet to follow us, we are on our LinkedIn platform as Design for Health by CC Hub. Please follow us on LinkedIn. You get so that you continue to get updates regarding our upcoming activities. Welcome you to follow us. I'd like to say my final thank you. I've said thank you several times. So yeah, thank you once again to our esteemed panelists and to all our participants. This brings us to the end of our session today. Thanks once again. Thank you.